few folks are still joining us, so we'll get started in just a minute. Thank you for joining us this afternoon for our discussion with Dr. Nicholas Volpe. My name is Andrew Christopherson, Assistant Dean of Development at Feinberg School of Medicine. It is a pleasure to welcome you, Northwestern alumni and friends of the Department of Ophthalmology, and to introduce our speaker, Dr. Volpe. A few housekeeping items before we get started. Thank you to everyone who registered and submitted their questions in advance. At the end of Dr. Volpe's talk, we have allotted time for him to answer as many questions as time permits. You may also use the Q&A feature to submit additional questions during his remarks. Also, this presentation is being recorded, and we will send a link to everyone who registered for the webinar. Our speaker today is Dr. Nicholas Volpe, Chair of the Department of Ophthalmology and holder of the George and Edwina Terry Endowed Professorship. Prior to being recruited to serve as chair in 2010, he was a full professor at the University of Pennsylvania. Dr. Volpe has published more than 150 scientific articles and book chapters, and his textbook, Neuro-Ophthalmology, Diagnosis and Management, is considered the definitive single-volume text in the field of neuro-ophthalmology. His awards include the Lifetime Achievement Award from the American Academy of Ophthalmology and the Stratzma Award for Excellence in Resident Education. During Dr. Volpe's 11+ years as chair, the Department of Ophthalmology has experienced tremendous growth and success in each of its interrelated missions: teaching, research, and clinical care. His updates today will highlight how far the field of ophthalmology has come in our understanding and treatment of various eye diseases. With that, I give you Dr. Volpe.
Thank you very much, Andrew. And to the audience, I appreciate you taking some time on this Wednesday afternoon to learn a little bit about ophthalmology and the department here at Northwestern. I apologize or disclaim to all the ophthalmologists that may be on this webinar or who may watch it someday that I don't pretend to be an expert in all of the things that I'll talk about. And I want to really thank some of my colleagues, which I will name intermittently, for providing me with a lot of the material that is part of this presentation. I really work, one message that I'll put out right from the beginning is the extraordinary group of people that I work with, both the support staff, people like Andrew and Catherine and Babette and Jordan, and all the people that are the supporting cast of characters, if you will, as we attempt to run our tripartite mission. And it really would not be possible, but even more so with the extraordinary group of physicians that are here at Northwestern. There's about 40 of us who are clinicians here, and I'd submit to you that there's no place better on earth to walk on the 15th floor of the Lavin Pavilion if you have an eye problem. It's really an extraordinary group of people that are expert in every way. I appreciate the people that sent some questions ahead. Where possible, I've tried to prepare and incorporate some of the answers to those questions, but I probably won't be able to get to everything. So with that, let's get started. I have nothing relevant here to disclose. I have some equity shares in a company that is making an OCT device that I won't discuss, and I do receive royalties from my textbook. You heard a little bit about me. I'm a native New Yorker. I grew up in New York City, and I went to CUNY and SUNY for my training. I did my residency in Boston at the Massachusetts Eye and Ear Infirmary, and then actually was at the University of Pennsylvania for 17 years. My own area of expertise, in addition to being a sort of master clinician educator, is in this type of surgery. It's adult strabismus surgery, so sort of fixing eyes that don't work together. And then my research interests are in optic nerve disease, pupillometry, or testing the reactivity of the pupil, education methodologies, and something I'll only touch a little bit on, but some of the interesting eye findings are retinal manifestations of neurodegenerative diseases such as ALS. I thought this quote was appropriate for this audience as we get started with our objectives, with a full understanding that it is for each generation to solve its own problems, and that no one has the wisdom to guide or control the next generation. I'll move forward. And I think that's particularly important and challenging as we come up to the second section of the talk about the practice and the profession and what it's like to manage this in the setting of a whole new way of doing medicine and medical care. And we're going to touch on some of the basic areas that are of general human interest, particularly cataract, retina, and glaucoma. We'll show some interesting stuff related to OCT. We're going to finally launch a full-time person, Chris Bowen, here at Northwestern in ocular oncology this summer. So that'll be a new service line that will incorporate well with our Lurie Cancer Center. And then I'd like to just describe for you some of the vision we have moving forward for Eye Institute. So you've all been through COVID and dealt with COVID. And, on one hand, we were very fortunate because COVID did not cause a blinding illness. And some of these studies, which I just picked out of the literature, would suggest that there is a fair prevalence of conjunctivitis or redness in the eyes that occurs in some patients with COVID. There is probably little doubt that tears could spread COVID. We went through a phase, of course, where everyone's wearing safety glasses to be very careful. But in the end, there haven't been much in the way of COVID manifestations, although a recent paper that I'll come up with in the retina section touched on a possibility of a increased association of some retinal vascular disease. But the hard part, of course, about the pandemic was we have a disadvantage as ophthalmologists, of course, because our faces end up about this far away from our patients' faces all the time. So we're at great risk of contracting respiratory viruses. And unfortunately, and maybe as you can see in this top right corner, that telemedicine and virtual ophthalmology may be around the corner. We're really not set up to do what we do as ophthalmologists virtually, because we have to examine the eye. We can't depend on history, x-rays, MRI scans. All of our tools and equipment involve examining the eye. So within 6 or 8 weeks of the shutdown and everybody staying at home, we were back in business, and pretty much have been so since the summer of 2020. Excuse me. So let's go to cataract. I don't have to tell this audience what cataracts are, the kind of visual experience that people develop with cataracts. Everyone who has gray hair has a cataract, right? You all have that sophistication to know that it's part of the normal aging process as the lens becomes cloudy. But not everybody needs cataract surgery. Our threshold, of course, is lowering and lowering because our technique is so predictable and so sophisticated. It's also a pathway to glasses freedom and not having to be dependent on spectacles. So as soon as it becomes symptomatic, this day and age, patients who have loss of acuity, loss of color, glare at night, certainly are considering for cataract surgery, right? The cataract being the lens, the cloudy lens behind the iris that's removed. And of course, some of the risk factors would be steroids and trauma in addition to advancing age. One of the thought leader process things that we do here at Northwestern is to do what's called femtosecond or laser-assisted cataract surgery. Dr. Bosti is our lead on that, and is the head of our cataract and refractive surgery. Here's a recent study that showed that it's probably equivalent to standard phacoemulsification. It takes a little bit more time. The advantages are in terms of how predictable it is in terms of placing custom intraocular lenses, positioning them, and getting the operation to turn out just as it needs to get the best possible vision. So I'll just show a quick video. I'm not going to show the whole thing, but just so you have an idea, this is a patient who is getting the first part of the cataract surgery, which is the femtosecond part. And you'll see this is the laser. You can see the person's iris and their pupil. And the laser is making an opening into the cataract and chopping the cataract into a bunch of little pieces. And then this is the view the surgeon would have when he or she moves to the operating room with the laser, having done a lot of the critical part of the procedure. And then we pick it up here, and this is the kind of view an ophthalmologist has when he or she does cataract surgery. The laser's already been done. The surgeon can take out the top covering of the lens or the capsule. And those of you that have cataract surgery, you all have your capsule left, and that capsule is what holds the intraocular lens. Once the top part of the capsule is cleared, then the material of the cataract is then phacoemulsified and removed. And all of this now is done fairly routinely under topical anesthesia. What's really revolutionized cataract surgery in the last 10 years, of course, are these premium intraocular lenses, which can both, to some extent, increase the depth of focus, so you can have both near and distance vision with some implants. And then with this particular technique, using toric IOL, and an intraoperative Callisto device, which actually helps the surgeon position the intraocular lens on the right axis. So now that's the implant in the eye here. Now the surgeon is positioning it based on some preoperatively made marks on the cornea to make sure that the astigmatism correction is lined up in the right way. So nowadays you can really move towards glasses freedom as a result of cataract surgery, which is very safe and very predictable. The newest kid on the block, if you will, are these light adjustable intraocular lenses. They're sort of ready for prime time. They are FDA approved. The concept here now is an intraocular lens that can be put in. Of course, you're getting it as close as you possibly can based on our formulas, which are often within a half a diopter or very little distance from perfect. But then the lens can be modified with light to change its shape to get the perfect correction. So this is a really exciting introduction to cataract surgery. It's quite involved. You know, the light part of it doesn't happen until 3 weeks after surgery, during which time you have to wear sunglasses and not be exposed to bright sunlight. And then based on what your refractive error ended up with, the surgeon can sort of plug in the necessary light to change the power of the prescription and improve your vision even further. So this is on the horizon, and there are people doing this now. We hope to be doing it here at Northwestern. Cornea transplant, the field has really changed dramatically in the last 15 or 20 years. You know, when I was a resident, all we could do is, this is a cross section, if you will, of the cornea. So here is an ultrasound of the anterior segment of the eye. This patient has a tilted intraocular lens, but we can get these incredible images. You know, through the 90s, all we could do is cut the cornea here, take it out, put a new cornea in, and that would be this version of it. In the last 15 years, we've become masterful at replacing only parts of the cornea. So the top half and anterior, deep anterior, but the most exciting ones are that most of cataract surgery now can just replace the diseased endothelium in procedures called DSEC or DMEC, where either the endothelium or the endothelium and the Descemet's membrane are protected, leaving behind all the normal cornea and just replacing the part of the cornea that's not working properly to keep it clear. And we've done a lot of interesting research here. This is Dr. Basti and Dr. Fetter on how to position these implants using ultrasound to make sure that these grafts, these things on the back of the cornea, are sticking and staying in the right place to allow for successful corneal transplant. Another exciting innovation, which I hope none of the people on this webinar need to take advantage of, is keratoprosthesis. Dr. Haddadine is one of our cornea specialists who trained at Mass Eye, where this technique was invented, if you will, where because of recurrent, this is an eye that obviously has scarring and blood vessels, can't take a corneal transplant, it just keeps growing blood vessels in it. So there's actually a synthetic or a plastic cornea that can be attached to a donor cornea, then attached to the eye in this form of a keratoprosthesis. And this can really revolutionize and restore vision in patients with scarred corneas. Onto the maybe less exciting, but more everyday. I bet there's, you know, half the people listening to this video have battled with some aspect of dry eye. And my message here is that, you know, dry eye is way more complicated than just get some artificial tears, which is what somebody might say to you. There are many, many layers into assessing patients that have dry eyes. And I'd encourage you all to make sure that you're with an expert or a front of the eye specialist that cares to think about your dry eye as you move forward. So it involves a proper assessment with history, exam findings. We can actually measure the volume of tears, the quality, the osmolarity, and all these things that would inform treatment. Remember, there are environmental factors, so making sure no new medications are contributing to your symptoms of dry eye, or some type of environmental factor in the place that you live, or when you change climates can be a factor. There's lots of other surface disease, particularly blepharitis or inflammation in your eyelids, that can be interpreted as dry eye that has to be treated. But then when it gets to the point of being treated, the first line, of course, is to use tears or some type of lubricant. Tons of different types, all with different preservatives. Your doctor may have his or her preference. You know, encourage you to sort of move through the different brands. You eventually get to the preservative-free ones, which are the small ones in the break open packets that are the least hostile to your eye, and maybe the best, but they are more expensive. But some regimen of natural tears is the mainstay of treatment of dry eye. A simple bit of advice, which I'm sure you've all heard: if you're waiting till your eye feels dry, then you've waited too long and it's not going to work. So the key for dry eye treatment is to stay ahead of it and develop a regimen where you put it in and at breakfast, at lunch, in the afternoon, at bedtime, and develop that routine. It's very easy to occlude your punctum with a piece of plastic so that your tears stay around for a longer period of time. There are some slow release tears. Lacrimal is another product that's available. Believe it or not, sometimes using a contact lens can help dry eyes because it keeps the moisture around longer. The two last 15-year guys on the block, Xiidra and Restasis, are both geared at treating inflammation of the lacrimal gland, which can help with dry eyes. Taking omega-3 oils might help with dry eyes orally, not in your eye. Occasionally steroids, and then in advanced ocular surface disease for people that have graft versus host disease or dry eye, we sometimes actually use your own serum to improve the health of the front of the eye by drawing your blood, spinning it down, taking the serum, and providing you with an eye drop that works with it. Another unusual condition that some of you may not have heard of is called keratoconus. In this picture up here in the top left, you can see what happens. The cornea becomes a cone and it kind of loses its refractive para. It gets a very steep axis to it. This is corneal topography. And there is good evidence to suggest that if you cross-link the cornea, it will stop coning or stretching out. So a procedure we've been doing here for the last 5 or 8 years or so is called corneal crosslinking, which involves soaking the native cornea in riboflavin and then exposing it to UV light. And that sort of, as you can see in this example, makes the cornea stiffer and less likely to cone and stretch. And this has been a revolutionary treatment to stop the progression in people who would likely be your grandchildren, maybe 20 and 30-year-olds that are potentially having keratoconus. Macular degeneration, of course, is probably the thing that most of us worry about in our lifetime. This is the one that can certainly be a game changer and involves a tremendous commitment in terms of treatment and doctoring. And you've all heard about this in terms of what goes on when we try to treat patients, when we successfully treat patients with macular degeneration with intravitreal injection. It's a huge problem, obviously 30 million people, much more common in lighter people with less pigment. Obviously there's genetics and vascular disease that are contributors, and wearing sunglasses, eating green leafy vegetables, not smoking, and having the right set of parents are really the best things that you can do to prevent having this. The classic description, if a neighbor describes it or you have it, is metamorphopsia, or this distortion of these straight lines. It's called Amsler's grid. If someone sees a bend or a warping of lines, that's very suspicious for fluid in their retina and a leaking macular degeneration, and of course, central blindness that comes with this condition. A lot of the complicated care that we deliver as ophthalmologists is dependent on all of the imaging we do when you come to our clinics. So it's not like the internist will send you for a CAT scan of your chest or an MRI of your brain. We're able to do all of our imaging at the same time, and that's what makes for a lot of our visits to be lengthy when you have to have your pupils dilated, your pictures taken, come back and see the doctor. And many of you, I'm sure, have been through this. But we have these extraordinary devices, optical coherence tomography with angiography, that can give us these incredible real-time pictures of the retina and its blood flow. This is the center of the retina, the fovea, if you will, where we see 20/20 and normal blood vessels. And now we have these incredible cameras that do wide field imaging and even wide field OCT. Here's what OCT, or optical coherence tomography, of a choroidal neovascular membrane. These pictures Dr. Gill and Dr. Mirza have given me. These pictures can sort of show that here's this abnormal gaggle, if you will, or tuft, of retinal blood vessels. This is neovascularization. Somehow our computer goes from this picture on the bottom to create what looks like growth of new blood vessels. And these are the things we can make go away with our treatment. We can cover even bigger areas and do even more interesting optical coherence tomography with a swept source device that gets a higher acquisition rate and is able to do these kind of things in the retinal periphery. Amani Fauzi is one of our leaders in retinal imaging. She's a world-renowned expert in OCT imaging and retinal imaging in general, with a particular interest in diabetic retinopathy. And we've actually discovered different layers within the thin retina, a superficial, middle, and deep complex of retinal blood vessels that help us understand the pathogenesis of someone like this with ischemic retinopathy from diabetes versus the normal appearance. And she likes to use the analogy of a lush forest versus a Chicago winter in terms of the density of these images. Mani also works with adaptive optics to look at the finer aspects of retinal detail through adaptive optics imaging. And of course, therapy, right? This is what some of you may have to deal with once a month in your life, and that's the treatment with anti-angiogenic agents through injections into your eye, right? So this is a beautiful OCT example, I think it's from Dr. Mirza or Dr. Lyon, of a large pigment epithelial detachment. And you can imagine that this person is not seeing clearly because this is more what the fovea is supposed to look like. So this is probably fluid that's elevating the pigment epithelium and distorting the retinal surface. Just after a single injection of an anti-VEGF material, all of that fluid is gone. So this is the same patient a month later with flattening out of the retina and restoration of normal vision. Unfortunately, the best studies show that these, while you can do this on a PRN basis, the regular injection of these materials, either usually Lucentis or Eylea, and in some cases Avastin, is the way that we treat all exudative or wet macular degeneration. There's a new kid on the block, Bevu, which is another MAB drug. This one seemed to have some promise for recalcitrant membranes and people that weren't responding to other therapies. Unfortunately, there's been some recent reports to suggest that it's in some rare occasions associated with an occlusive vasculitis of the retina. So we're a little hesitant to use it unless it's absolutely necessary. Some of the newest and exciting things, Genentech has come out with a port delivery system. So in an option, maybe a new patient, somebody who doesn't come back and forth or chooses this as a safer and easier option, is to have a port, and this is now FDA approved, placed pretty much where you get your injections, but it has to be done surgically. And it sits there, and then this port delivery system can have a refill every 6 months or so. So you'd only need a quote injection twice a year once you've had the initial treatment. Probably some of the more exciting things are things that are on the horizon that are emerging drugs, particularly for dry. I didn't spend a lot of time on this, but they're the start of macular degeneration, if you will, are pigment changes, atrophy, and the accumulation of these lipofuscin-rich drusen. You've probably heard your ophthalmologist, or if you are an ophthalmologist, you know what drusen are, accumulating. Drusen become the nidus, particularly when they get large, for the growth of these neovascular membranes. Well, in that case, again, the drusen themselves may not be too harmful, and we have a decent treatment for when it triggers the growth of new blood vessels. But the bigger problem, even after treatment for wet AMD, is the slow and progressive, what we call geographic atrophy, that accompanies patients who have the dry form, or just the age-related accumulation of light, oxidant damage, whatever it is, complement damage that's triggering the atrophy of the retina that eventually leads to poor vision and loss of central vision, either after the wet phase or completely independent of the wet phase. And that's really the holy grail of treatment. The dry stage is what we did the ARED study for, which have shown that some of the ocuvites and other things that may help slow the progression of that, those have only really been shown to be effective in patients with the late stage of dry AMD with large soft drusen. And now having a potential treatment for something that slows the area of atrophy as it's growing could be a true game changer. So this pegcetacoplan is a potential treatment that is now gone through phase 2 trials and is very promising for potentially treating through a targeted C3 pathway. And it's a drug that comes from Apellis that might eventually show that we can slow the progression of geographic atrophy. So I think that's going to be one of the hot areas over the next 10 years, are drugs and other things that are developed to try and spread or try to slow the spread of the dry atrophy or geographic atrophy. I don't refer to them specifically here. There are some gene trials as well for macular degeneration. We don't have the gene for macular degeneration. Obviously, there's a host of genetic factors, but there are some potential gene therapies that enhance or reduce the production of complement and other factors that may prove to be valuable treatments for macular degeneration. Stepping aside, the newer and exciting gene therapies are the true replacement of known genes. All of you have heard of the Luxturna treatment for RPE65. That's the replacement of the necessary gene RPE65 in patients with Leber's congenital amaurosis. That's now a commercially available procedure. There's probably only, I don't know, 100 patients in this whole country a year that would benefit for a treatment like this now that it's been out there, but it is certainly, most importantly, proven a proof of concept, both for gene therapy in general for the human body, and specifically with the relative safety of delivering genes via adenovirus vectors into the subretinal space and allowing those viruses to spread the new and healthy gene to disease cells in a very effective way. And some of the current treatments, choroideremia, achromatopsia, Stargardt's disease, these are all conditions which are now in early phase or phase 2 trials for successful treatment of these inherited diseases, which were previously not thought to be any possible, not available, no treatment was available. In the operating room, retina vitreous surgery is some of the most difficult and precise surgery we do. We use an Artivo system at Northwestern, which is a Zeiss product, which it isn't for every case or needed for every case, but it allows for a 3-dimensional polarized glasses version of doing microsurgery that allows for simultaneous use of optical coherence tomography. So this is a view a surgeon might have as she is operating on the retina and looking at the actual surface in a cross section through a simultaneously projected OCT on the screen. And there are a lot of things, not only teaching, but the actual surgery that are enhanced by using these 3D heads-up displays. So it's not necessary or part of every case, but intraoperative OCT and the heads-up display are becoming a very big part of both retina, that is posterior segment surgery, and also very often used in anterior segment surgery, for instance, in positioning the graft of a DMAC or an endothelial keratoplasty and making sure it's in position, that the air bubble is holding in place. So the technological marvels that are available to ophthalmologists during surgery are really quite extraordinary. Segue here, it'll come up a couple other times as I progress through the talk into augmented. People like to use artificial. I like the word augmented intelligence. There's nothing artificial about it. It's just using a machine that is potentially smarter and faster or able to see things that we're not, and apply those abilities to make observations to help us be intelligent about how we treat people. And if you think about it, ophthalmology is really the perfect field for the applications of augmented intelligence, both for screening, and we'll talk about that in diabetic retinopathy, but also in potentially having a computer or a artificial brain or something that can mash through lots of ones and zeros, be able to look at a bunch of pictures over 20 years and see something 20 years ago that is a common predictor of how things are going to look 20 years from now, and something that we have never recognized. So I think one of the most exciting opportunities we have in ophthalmology, because we take so many pictures and we have so many documentation of how diseases progress, that we'll be able to add these images to a computer, and they'll be able to say, this is a person who's going to get wet macular degeneration. This is a person who's going to progress from glaucoma. This is a person whose diabetic retinopathy is going to get worse. And it's turned out that computers can see things that we can't see. So I mentioned it here in this bullet down here. So there is an artificial intelligence program that can look at someone's retina and predict their gender at about a 90% rate of accuracy. That is something that I can't do. I mean, all gender retinas, whether they're XX or XY, look all the same to me, but there's obviously something unique that a computer is able to detect from looking at hundreds of thousands of imaging studies and making that. But the real key is going to be in screening, particularly for diabetic retinopathy, and predicting the course of how diseases are going to progress, particularly macular degeneration and glaucoma. For diabetic retinopathy, this is the most common cause of new blindness in the middle-aged working group, right? macular degeneration, fortunately, for our working productive adults is usually not an issue until you're over 60. About more than 5 million adult Americans, and it's only going to get worse with the prevalence of hypertension and diabetes. I just put some examples here of some of the things that people are looking at. The paper on the left, a recent paper that looked at biomarkers and seeing how, for instance, cystatin, which apparently, and maybe some of the internists on the call know that biomarker as an indication of someone with high cystatin levels may be more likely to progress. I'm not sure this line of reasoning and thinking is as effective and as important as the ones portrayed on the right side of the screen here. And that is, I have no doubt in my mind that we will have the sophistication in the very near future to hold your eye up to your iPhone camera with even potentially without your pupil dilated, have some ability for the camera to subtract for what you're doing wrong, moving your hand, looking in the wrong place, and create a reliable screening image. And some of these studies that I'm noting here are showing great success for that. We have a very established program in diabetic retinopathy screening using non-mydriatic cameras. The hard part is getting doctors and patients together to take the pictures, not ophthalmologists, but internists. So if we can bring this to people's pockets, I think that's what's going to finally make a difference. Lee Jampol, who some of you may know, my predecessor, is one of the leaders of the Diabetic Retinopathy Clinical Research Network, which is really the gold standard for determining the various best treatments for diabetic retinopathy. And they're now up to double letter protocols. Here's the results of W, which basically showed the difference between VEGF and vitrectomy for diabetic hemorrhage. But they've done really 30 or 35 really important clinical trials that have really defined how diabetic retinopathy is treated. And the only problem with treating diabetic retinopathy are the people that are sitting not 5 miles from where I'm sitting, who don't know they're going blind and don't have access to care. So that's something important for us going forward. I don't want to spend too much time on this, but this is an interest of mine. There is no doubt that the neurodegenerative diseases, particularly ALS and Alzheimer's, affect the retina. I don't think it affects it to the point where people can't see, but it affects it to the point where we're able to detect various changes in the retina. Whether we'll be able to use our imaging techniques to detect it and monitor treatments is to be determined, but that's another interest of ours here at Northwestern. A couple of human interest articles that may have passed on your radar in the lay press or medical press. There's a very recent paper just this last month about potential risk of the erectile dysfunction drugs for ocular adverse side effects, probably associated with ischemic optic neuropathy, something I know a lot about. But there are millions and millions of doses of these drugs every month. This was sort of a database type of study where someone took the hundreds of thousands of patients who did take these medications versus the hundreds of thousands that didn't. And they controlled for all the other variables, and they just showed a slight increased incidence of retinal vein occlusions and other vascular things. I don't think it's relevant, and I don't think anybody should hesitate to take these medications either for erectile dysfunction or any other condition in the absence of known and previous retinal vascular disease or optic nerve disease. In that setting, it might be worth having a conversation with your ophthalmologist. And as I alluded to earlier on, here's one paper that showed a slight increase in retinal vascular occlusions on the venous side, not arterial side, in patients who have had COVID. Those of you who take care of cancer patients, an increased incidence of orbital and optic nerve inflammation in all the new immune checkpoint inhibitors. So patients with visual symptoms in that setting should be you should get to a neuro-ophthalmologist. And we have one genetic disease that some of you may have heard of, Leber's hereditary optic neuropathy, which is a mitochondrial disorder that may someday be treated with gene therapy, but so far we've not been successful. Now, this slide is courtesy of Chris Bowen, who's our new ocular oncologist starting this summer. There's finally been a study that has shown an effective treatment for tenbentafusp. I'm sorry if I'm saying that wrong, but a medication that has reduced the the death percent at 1 year with metastatic uveal melanoma to as high as 45% survival, where in the past it was only 20%. So some hope for patients with metastatic uveal melanoma. Switching gears to glaucoma. So this is another, it's a less dramatic disease than macular degeneration because you have it for a lifetime and you sort of get numb to the chronic necessary follow-up, and all of you have dealt with this in some form or another. More prevalent in Black populations and family histories. In a good percentage of people, it's a pressure-driven disease, but 25% of patients do not have high pressure, and pressure is not necessary for part of the diagnostic criteria. We see this characteristic changing of cupping of the optic nerve as seen here. The way it, quote, blinds you is to slowly lose your peripheral vision. Those of you that have done visual field tests, this is the type of output that shows that this patient is experiencing blind spots, usually around their center vision. The center vision is the least to go. And I think, home pressure monitoring and monitoring the progression of glaucoma is certainly going to be helped by augmented intelligence as well. Most of our follow-up now of patients with glaucoma involves using OCT. Here again, we're not looking for fluid and blood vessels as we do in macular degeneration, but we're looking for the thickness and health of the ganglion cell layer, this is the ganglion cell layer of normal thickness in a patient with glaucoma, and the nerve fiber layer. So these are very robust, objective ways of measuring changes slowly over time to help us develop target intraocular pressures and know how effective we are, and recognize that here's another place where deep learning and augmented intelligence is certainly going to help us detect this sooner, and more importantly, predict who's going to go bad. Because there are plenty of people walking around with pressures of 30, which is high, who never go blind, and many patients even with pressures of 15 who still go blind, and we have to be able to distinguish those patients. Some of the drugs, of course, the mainstay is prostaglandin analogs, which are a once-a-day drop like latanoprost that you take at night, or Zalatan, beta blockers, alpha antagonists. These are make less aqueous, and the other drugs sort of enhance the outflow. We have good surgeries for glaucoma. The current primary procedure is often something called a tube shunt, which is some version of this piece of plastic, which is sewn to the sclera under the conjunctiva, and a small port, if you will, is put into the anterior chamber, which allows drainage of fluid. This turns out to be equal and probably a little safer than doing straight trabeculectomies. There are some people that need trabeculectomies, which is a little riskier and a little less predictable surgery, but both of those are available when medications and lasers are not effective. The newest kids on the block are these devices called MIGS, or minimally invasive glaucoma surgery, MIGS. You'll see that abbreviated. Those of you who take 1 or 2 glaucoma medications that are also having cataract surgery, your cataract surgeon say, well, why don't I put an iStent or a Hydrus or some of the other various non-incisional, so these don't make a bleb, but they somehow allow your trabecular meshwork to work a little better and more effectively in draining them. And some of them just bypass the trabecular meshwork directly. Some of them go into the suprachoroidal space, but they have been clearly shown to reduce your dependence on medication when you're a glaucoma patient, but not necessarily to change outcomes. So it's more while we're there, we'll do it, and hopefully we'll help you. We have specific interest and experience with a GAT procedure, which is another version of a minimally invasive glaucoma procedure where a proline-like tube is sort of thread through the trabecular meshwork, which you kind of see it going. This is a gonioscopic view into the angle of the eye. Once you have it in there, you actually cheese wire to pull it through to sort of open up the trabecular meshwork. And all of these have been studied against each other and versus other non-medical approaches to glaucoma, and have all been shown to be somewhat effective and desirable in further lowering the pressure, and more importantly, making your dependence on medications less. There's currently the COAST trial clarifying optical application of SLT therapy that's ongoing. We're a center here at Northwestern. This is using a lighter version of laser trabeculoplasty. So actually putting laser into the angle of the eye and using that to improve flow. And this was a UK study showed it was effective. And we're doing this now. And there's a couple of points at which patients go in and out of this study depending on their pressure. And I think this has a great chance of becoming the primary initial therapy in patients with glaucoma, even before you try drops, just to have this light laser once or twice a year as an effective therapy. For oculoplastics in orbit, these slides are courtesy of Liza Cohen, who's one of our new oculoplastic surgeons. The game changer is, of course, teprotumumab. Most of you have probably heard about it, and this is an IL-6 inhibitor that can actually reduce inflammation in thyroid disease, and you can see some very dramatic results and improvement in eye muscle swelling, proptosis, injection. There's no doubt that this works, and there'll soon be many other competitors in this market. Just as an aside, I thought this was funny, this study, when I came across it a couple of days ago. So someone actually looked at how often people were searching thyroid eye disease once Horizon, which is the company that makes Tepezza, started putting the TV commercials on every Hallmark show or whatever channel you watch. And all of a sudden, thyroid eye disease has made it to primetime television, and people are wondering whether Tepezza is right for them based on TV ads. So sort of an unusual aspect of our society as you watch television. Vismodegib is another interesting potential anti-medical, anti-basal cell treatment. A study that Alon Kahana, who's in Michigan, did and showed this can be very effective in treating basal cell tumors. I apologize for the graphic nature of this slide. Anyone who wants to cover their eyes. Two other interesting things that we're doing that are novel ways of approaching disease of the orbit and eye socket. One of the tough things we deal with as ophthalmologists is neurotrophic keratitis. If the cornea doesn't feel, it doesn't epithelialize well, the surface breaks down, it can be very devastating. There's now a technique called neurotization, where you basically attach either a patient's graft from the sural nerve or a cadaver graft to the infraorbital nerve, and then sort of sew them together and then attach that subconjunctivally to the areas around the cornea. And this has been shown to reinnovate the cornea. Our endoscopic surgeons, in conjunction with ENT, have gotten even more sophisticated in getting at tumors that are behind the eye through a combined transcaruncle plus through the nose delivery of orbital tumors via endoscopic techniques. So the whole field of skull-based surgery has really evolved. So with that, I'm going to change gears a little bit and just talk a little bit about what's happening in terms of the training and the environment in ophthalmology. I think these quotes, I use them in many of the talks I give as I think about what we're going through as a profession and what our successors are going to go through. And one of the hardest things to acknowledge is that the world is changing. We have to change with it, as opposed to really embracing the way we thought things should be. Faced with the choice between changing one's mind and proving there's no need to, almost everyone gets busy on the proof, right? And we're all sort of tied into this idealized path. Thanks to all of you and me, we're making about 10,000 new Medicare patients a day. There'll be about a 75% growth in the amount of cataract surgery we do over the next 15 years, with our population to be 88.5 million people over age 65 by 2050. These are ophthalmology patients, and we're not making any more ophthalmologists. We're not increasing the number of training programs. So how we deal with this is really going to require a paradigm shift in terms of how we deliver care, who delivers care, who provides the surgery, what setting they do it in, who assists, and how we approach that. And we're trying to get out ahead of that and think in novel ways, but for the most part, we're all still stuck in our day-to-day. Another external force that's really interesting in ophthalmology is the, I'll use a tongue-in-cheek term, invasion of private equity companies into the ophthalmology sphere. So a lot of private equity companies are using ophthalmology practices to monetize, get it efficient, and then sell it to a bigger private equity company. And the doctors who have put hard work into those practices are able to monetize all their hard work. It's not a good long-standing model for the next generation of ophthalmologists and where they might practice. So I'm excited to see this happening, not for my profession, but I think it'll give large system-based academic medical centers a great advantage as they move forward and try to hire and grow in a geographic region. But this is a very real change that's affected our generation of ophthalmologists that have used this as their path out of or for extracting value from their practices. If you think about it, just from what I've talked about in the last 40 minutes, intravitreal injections, OCT, femtosecond cataract surgery, none of these things were available when I was a resident, and that was 28 years ago or 30 years ago. So things are going to change, technology is going to change, and how we change with it and how we teach our residents is a zero-sum game, and we really have to think about not sort of embracing our way as the only way, but accepting the fact that things are changing. Some of you may know this and may not. The internship year is now incorporated into ophthalmology residency. So our program here and all programs across the country by 2023 have to incorporate their internship. This is something that I led the national mandate on, and it's just been a critical addition to our program. They still do a traditional internship, and they're in the ICUs and the medicine floors and the surgery, but they're on our site. They have 3 months of ophthalmology. They come to our conferences. By the end of this internship, they've become very sophisticated at the eye exam, very comfortable in their work as ophthalmologists. So adding the internship or not sending people to a different place for their internship has been a great change over the last 5 years in ophthalmology residency. Our program here is largely based at NM. Of course, at Lurie Children's, we have Brenda Bonesack as our new division head she moved here from Michigan, has really done great things. And we have a significant presence at the Jesse Brown VA. We're less fractured. There's a lot of continuity. There's less lectures. It's very, very different than it was in the past. And one of our newer and exciting things is thanks to a very generous gift from Ron and Athena Ches. We've established the Ches Microsurgical Teaching Laboratory. So the technologies for simulation now are so sophisticated that we really can do this sort of a classroom style schematic, where this is the room now as of about 2 weeks ago, and it should be finished by the summer, where we have these stations where people can be taught remotely, their videos can be sent to conference rooms, and really gives us this great privilege of treating the next generation. Anybody's interested in how and what our ophthalmology residency looks like these days, I encourage you to visit the website because there's some good videos and other things there. Here's another interesting trend. This is hot off the press of the most recent match in ophthalmology. If you can see this, it's a little bit hard to see, but you can see that ophthalmology has gotten increasingly more popular. So the number of applicants, I'm just talking about US senior graduates from MD schools, and you can see it's creeped all the way up into the 625 range with only 75%. So unfortunately now we're back to 1 out of 4 who wants to be an ophthalmologist not matching. One of the casualties, if you will, of that is now the average applicant applies to 81 programs when they apply for residency, which is obviously ridiculous and not something that we're able to figure out a way to curb, because people will apply to more and maybe I'll get more interviews and that'll increase my chances. And we're working on that in terms of solving things. Tenny Brown is one of our obstetrician gynecologists. She just gave us a talk and I kind of screenshot and stole these slides from her. Just a really wonderful forward thinker about how race and gender affects our impression of residents. And I'm not going to go into the details here, but there are clear differences on how we pick, how we write letters about men versus women applicants, Black versus white applicants. And this is something that this medical school is very tuned into getting right as a community that is interested in having a truly diverse school that is not biased and provides care to all the peoples of Chicago. And then the last very disturbing trend in ophthalmology is that our fellowships have proliferated. So this is an older slide, but in the 2019 number, I think it's up over 72%. So if we have 72% of us doing fellowships, who's going to take out all those cataracts? Who are the comprehensive ophthalmologists? And that's something that I personally give a lot of thought to about what we can do to make comprehensive ophthalmology a more attractive specialty. And then finally, as we go through into this last few slides, I just wanted to share with all of you where I think and hope I'm headed as the chair of this department over the next decade. And if you think about everything I've said and all the novel and great treatments that I introduced, and we made eye care completely free to everybody who can get it whenever they want, there would still be a lot of blind people or a lot of people with vision disability. And there's really 3 reasons for that. And the reasons are because even though we've advanced the treatments, we don't fully understand the pathogenesis, we don't fully understand our treatments, and we don't fully understand the importance of intervention and detection early on. And that's the only translational research will change that. And only the types of research that we're doing here and in other places will be important. The second issue is that even in the best case scenario, there are going to be people that end up with damaged retinas and optic nerves. We still have no ability to replace damaged optic nerves or retinas or attachments to the brain. And that's a critically important issue. And then the third issue is much, maybe lower hanging fruit, maybe even higher hanging fruit. And that is, even with all this wonderful treatment, as I said, in a somewhat glib fashion, there are people 5 miles from where I sit that are going blind from completely treatable eye diseases because they can't access care or they've not been screened to do that. So we have a vision here to establish an institute, not so much a building. I show this slide sort of tongue in cheek that it would be a building, but more a destination and a cohesive way of delivering care, doing education and research together at Northwestern. Over the last 10 years, both the hospital corporation and the medical school have made tremendous investments in ophthalmology, and we've really accumulated a critical force of vision scientists, researchers, clinical researchers, educators, great training programs, and really state-of-the-art clinical facilities. So hopefully with this Eye Institute, we'll really dedicate this group of people to expanding our knowledge. Those of you that are here or know about Chicago, our practices in the Lavin Pavilion. This is our current version of it on the left. This gray area is now becoming these white rooms as we speak. So as of September, we'll have about 100 exam rooms here down on the main campus for our academic tertiary care practice. I'm sorry about the abbreviations. I just want to cover it. We have a practice open now in Evanston. We'll open in Irving Park in June. With that, Bronzeville, a year after that, we'll have 4 locations centrally. We have 3 practices up in the north at Lake Forest and Glenview and Grays Lake, 4 practices in the west, and hopefully to be in the Palos region soon. So we'll have 12 practice sites that are screening, taking care of cataracts, doing the basic things. And then we'll have some of our subspecialty care and certainly our quaternary care here down at Northwestern. We'll have this Eye Institute that, on the right side here are all the issues that we talk about in terms of changing the way we think about problems, our retinal synaptic physiology program, our vascular ophthalmology program, stem cells, all the things that I believe are important in transforming the way we think about vision. Somewhere in the middle are the things that overlap in terms of clinical research, primary care access, quality, global ophthalmology, and then all of our elite clinical programs over to the left, where we're doing truly state-of-the-art. There's no care on earth that someone can get that they can't get at Northwestern at this point. And then maintaining our fierce commitment to education. So this is where I'd like to see it go. We have a vision for an Eye Institute that includes various centers of excellence, particularly in vascular ophthalmology, synaptic physiology, and even more important, there are probably almost twice as many vision scientists at Northwestern. We double the number of vision scientists if we include people outside of ophthalmology. So for those of you that measure things by grants, we have 9 R01 grants in the ophthalmology department. There's 19 at the university. So there's from the Eye Institute. So there's a very rich community of vision scientists here at Northwestern that I'd like to bring together, doing research in all these important areas that we've touched upon, and I've sort of pounded my chest on as the critical aspects for the future. These align well. This is the National Eye Institute strategic plan, and you can see things here that exactly overlap with the kind of things that we're interested here at Northwestern. So our growth will be clinical. It'll be on the discovery side. It'll be on the education side. And it'll be with this wonderful group of philanthropic people that have embraced this. We've been able to raise a lot of money over the last 10 years to be able to support this growth. And there's no stopping us now as we try to build and enhance our program. So I'll wind down there and just welcome all of you to have any additional questions and anything I can answer. This is a little bit older photograph of some of the colleagues that some of you may recognize. There's just extraordinary people that we work together. Alice Lyon, who's the head of our retina surgery, retina department, is the most compassionate, best visual retinal surgeon on earth. Deborah Goldstein, Manjo Gill, Rob Fetter, Gary Listner. There's just an incredible, Dimitri's our residency director, Surendra is the head of our cataract surgery program. We have just an extraordinary group of people, our pediatric people down at this end, that work here to care for people's vision. And people should go and think about Northwestern as that's where they saved my eye. That's the reason I can see. That's the place that's doing discovery. And that's the place that's educating the next generation of ophthalmologists. So thank you for your attention. I hope I touched on some or all of your questions. I can stick around for a few minutes if there's any additional questions, if we have a few minutes left, and I'll turn it back to Andrew.
Wonderful insights. Thank you so much, Dr. Volpe. Very, very informative presentation. At this point, we'll get to some of the questions that were pre-submitted, and we just got one in the Q&A feature. Dr. Volpe, what advice would you give to a pre-med undergraduate student who is considering a career in ophthalmology?
So at the college level, right, the advice is to embrace some aspect of vision science if you'd like to do it, or community service, or connect yourself with the world of vision. And that could be global, it could be community service, it could be hardcore basic science, like, just something to whet your appetite further. You don't have to do anything at that point in your life to make you a better ophthalmology applicant. You just have to become someone interested, and you have to do all the things that are necessary these days to get into medical school, which isn't so easy.
Great. Thanks, Dr. Volpe. Quick question related to prevention. You mentioned wearing sunglasses, eating vegetables, and not smoking. What other preventative measures do you suggest to your patients and others to prevent vision-related issues?
Wearing safety glasses whenever you do stupid things that involve high-speed tools or balls or anything like that. I think probably the best message there would be, everybody thinks, kind of scoffs at ophthalmology or doesn't think much about it until they have a problem. And so many of our diseases, certainly diabetic retinopathy, cataracts, glaucoma, macular degeneration, all have ophthalmoscopic manifestations long before they're causing symptoms and long before they threaten your vision. So you get to 60, you got to plug in with an ophthalmologist and get regular eye exams. And again, most of the time you can do that, and most people get away with it. But when you don't get away with it, that's when you're going to wish you had in the past. So don't ignore symptoms, and be careful with your eyes, and see an ophthalmologist once you get to be older.
Thank you, Dr. Volpe. You've certainly been busy and accomplished a lot in your 11 plus years at Northwestern. What are some highlights? And then you did paint the picture for the future with the Eye Institute, but if you could just comment both on the last 11 years and where you hope to go moving forward.
Yeah, I mean, I think the thing that stands out to me over the last 11 years is the type of investment that both the health system and the university have made in eye care and vision discovery. So a lot of academic medical centers, ophthalmology sort of marginalized, and it's not a big bottom line producer, and people aren't willing to invest in it as a critical part of the mission. That couldn't be further from the truth here, on both sides. We have a beautiful clinic that has been built and built again and made bigger because the health system believes in it. They're investing in putting practices all around the area so that we have access to those things. The best technology, again, is in our operating rooms and in our clinics, so no shortage there. And Dean Nielsen has been very supportive of my vision and the recruitment of key people going forward. And I think that's what's really changed the most. I'm all about first who, then what. And if I get the right people on the bus and they all have the same vision, despite the very stressful times of the pandemic and the overall sense that a lot of doctors have that it's harder than it used to be, we have a lot of very like-minded people that, as academic ophthalmologists, again, right, there's a lot of ophthalmology can happen in the community. You can get your cataract and your retina detachment all fixed in Paoli, Pennsylvania. That's probably almost as good. But if you put together complex problems that affect more than one part of your eye, and you need a collection of experts together that can define care, that is only going to happen in a major academic medical center. And in Chicago, I think, and I predict, that's always going to be Northwestern.
Thank you. We just got a question on the Q&A feature regarding the November JAMA report on the study relating cataract surgery to improvement of brain health. Any sort of comments on that particular study?
Yeah, I did see that when it came through. I think there is, if you use the argument that the better you do things with your senses, the better your brain is at maintaining its function. So I do think that there is lots of good reasons to think that the best possible vision is consistent with the best possible brain health. To me, it's a little bit of a stretch when you talk about correcting a 20/25 cataract, but certainly in the setting in which visual deprivation or impaired vision affects one's ability to engage and do things with their eyes and probably any sense, it's not hard to predict, that brain health would be connected to that. And there are other studies that have shown that, that just one eye, even one eye disability is enough to affect quality of life in a way that is, harder to imagine than it would. You say, I see perfectly out of my right eye, my left eye is okay, but that does affect the quality of your life in a lot of ways that, again, most of us, thank God, are able to take it for granted. But until you experience this, and this is hard for patients because we see a lot of patients and you're moving through quickly and trying to explain things to your ophthalmologist, and we're pretty much pattern recognition people. And if we don't see the cataract or the macular degeneration, we sort of duck out. And I think the part of the experience that vision is part of is really a critical thing that we have to pay attention to.
Thank you. We also got a question just submitted here, your relationship to optometry, and that's all the question said. Any sort of comments?
Yeah, no, I mean, I think the optometry, co-practice of eye care with optometry is a key focus of mine. There are lots of things that optometrists are good at and ophthalmologists aren't as good at and don't want to do as much as. It gets tainted with a little political fodder because of the scope of practice issues. And I don't personally think that optometrists have the training to do surgery or to prescribe certain types of medications. But my vision is that co-practice with optometrists and ophthalmologists is the way it should be done. And it ensures that more patients have more access to care, and that ophthalmologists should work at the top of their license and optometrists should work at the top of their license. And hopefully we as professions can work that out as opposed to working it out in courts or in legislative bodies.
Great. Thank you, Dr. Volpe. Well, we are just at about an hour, so want to thank you again so much, Dr. Volpe, for your time this afternoon and for sharing your expertise. For anyone who joined us partway through the webinar, a link to the recording will be distributed in the coming days. And finally, to the Northwestern alumni, especially the members of the Half Century Club, and to the supporters of the Department of Ophthalmology, we greatly appreciate your time today and your continued partnership. We hope you enjoyed the virtual program and look forward to staying in touch. Thanks again. Have a good evening.
Thank you, everyone.